supportive care drugs in oncology. And for today's session, our program director is Dr. Prashant Mehta, sir. Sir is a senior consultant and program head at for lymphoid neoplasms and cellular therapy at the Department of Hematology at Amrita Institute of Medical Sciences, Faridabad. So I hand it over to you, sir.
Thank you. Thank you so much, Karan. Really, I'm so happy to see how this Gurukul is actually panning out. And thanks to you for being, one of the real torch bearers and taking the Gurukul legacy forward in a great way in the virtual world. And I see such great and such amazing speakers and faculty teaching in the Gurukul these days. And we had great faculty for solid tumors recently. And I saw Dr. Senthil, the likes of Dr. Senthil, Dr. Vijay Patil, and amazing Dr. Padmaj Kulkarni, and such amazing teachers all shared their wisdom with the students. And I'm very hopeful that students would be really learning a lot, and they would be benefiting even for their exams with this initiative. And as we go forward today, we have some amazing faculty for the hematology part of this Gurukul, which as of probably starts today. And we have one of my great friends and teachers today, Dr. Ranjit Sahoo, here today. Faheema, again a great dynamic speaker and dynamic faculty from hematology. And we have Professor Dr. Reena Nair also coming up, Lingaraj coming up. So many amazing speakers coming up to share their wisdom and teach our young brigade. So I just would want to also thank our course directors, Dr. Purvish Parik and Dr. MB Agrawal, who have been such a pillar of support in all our initiatives, all our Gurukuls actually. From every kind of support we have received from them, and thanks to them always. And for this initiative, I think we have the supportive care drugs today, session today. And it's a very important Gurukul today. So I'm very hopeful, and I would just hand it over to Dr. Faheema to take it forward from here. And I wish all the students the best for their exams, and great learning. Wish them all great learning. Thank you, Karan.
Well, thank you so much, sir, for taking out time. Thank you so much.
Hi, I think it's my time to talk. We all know that supportive care is the pillar of, oncology care. Basically, the outcome of the patient is solely dependent on supportive care and proper nursing. We are all aware of that. And I think this is one of the most important talk all of us must be aware of in order to improve the patient outcomes and the quality of life, and especially to make sure that the patients have the confidence in us to undergo the whole treatment. So without much ado, I would ask Dr. Akansha, who is a consultant medical oncologist from DMCH Cancer Center, Ludhiana, to give us a brief talk on drugs and supportive care. Over to you, Akansha.
Thank you so much, ma'am. And I would like to thank the organizers for giving me this opportunity. And the topic given to me today is drugs in the supportive care. So basically, this topic I was told to present this topic just 2 days back. And it's such a vast topic. I have tried my best to cover the slides as far as possible. And in next 45 minutes, we'll be talking about drugs in the supportive care. So without any delay, I would start with my presentation. I think my slides are not moving.
Just a minute, ma'am. We'll get back to you.
I'll stop sharing and I'll try sharing again.
Ma'am, you can just reshare, and once clicking on the screen, then you can reshare it once. Yes, please click on the screen.
Yeah,
and
okay, fine.
Yeah, thank you.
So I'll be covering my presentation under these headings. I'll be covering drugs in the chemotherapy-induced nausea and vomiting, drugs in the febrile neutropenia and infections. Mainly, I'll be covering antibacterials and antifungals over there, and drugs in the chemotherapy-induced thrombocytopenia, and again the VT, few slides on the VT. Can you see my slides?
Yes, we can see the slides.
Basically, I cannot see my slides.
Ma'am, do you want us to share the slides? Or?
No, I'll just continue with this. So yes, starting with the chemotherapy-induced nausea and vomiting, as we know that there are 5 types of CNV, that is acute nausea, chemotherapy-induced nausea and vomiting, which develops within the first 24 hours after the chemo administration, delayed CINV occurring for more than 24 hours, and it lasts up to several days, anticipatory nausea and vomiting due to the conditioned response to prior episode of CINV, breakthrough emesis, and refractory CINV. So this is the pathway. Basically, there are 2 pathways. One is the peripheral pathway and one is the central pathway. Peripheral pathway, what it happens is when the chemotherapy is given, it goes and affects the GI cells from where there is release of serotonin, which is 5-HT3, which binds to 5-HT3 receptors, which in turn stimulates the chemoreceptor trigger zone present in the area postrema, which again stimulates the vomiting center and causes emesis. So this is the peripheral pathway. This is responsible for the acute onset nausea and vomiting. Another is the delayed pathway, which is due to the central pathway. What happens there is release of substance P, which actually activates the NK1 receptors, which further stimulates the CTZ and vomiting center, which causes emesis. This delayed pathway is due to the central pathway. As we know, whenever we talk about the nausea and vomiting caused by chemotherapy, we have to divide the drugs into 4 classes based on the proportion and frequency of emesis it is causing. So one is the highly emetic drug, that is in more than 90% of the patients. Then come the moderate emetogenic in 30 to 90%. In 10 to 30%, it is the low, and less than 10%, it is the minimal. So talking about high emetic risk potential drugs, whenever we talk about these drugs, we have to say that we use a 4-drug regimen, which is continued up till 4 days. So these takes into account the first class of drug is NK1 receptor antagonist. We can use the oral form as well as the IV form. The oral form is in the form of aprepitant, and which comes as a capsule, 3 capsule packing. On day 1 we give 125 milligram. On day 2 and day 3 we give 80 milligram on day 2 and day 3. Then another oral form is netopetant and palosetron combination, comes as dose of 300 milligram netopetant and 0.5 milligram palosetron. This comes as a fixed drug combination, which is known as NEPA. This I've shown in this picture. This is the single capsule of NEPA. Then IV form also we can use, which is by the name of fosaprepitant. The dose is 150 milligram given only on day 1. The next class of drugs is 5-HT3 receptor antagonist. The most common we use is ondansetron. The dose is 16 milligram given only once on day 1, and this comes by the name of MSET. Others we can use are palasetron, dose is 0.25 milligram IV given only on day 1, or granisetron. The dose we usually use for the practical purposes is 1 milligram given on day 1. The next class of drugs is dexamethasone, which is corticosteroid, given 12 milligram on day 1, and it has to be continued as 8 milligram on day 2, 3, and 4. And the last class is olanzapine. The dose is 2.5 to 10 milligram. Initial trials showed that 5 to 10 milligram dose has to be used, but one Indian study has been done which showed that 2.5 milligram is non-inferior to 5 or 10 milligram. So we can, for practical purposes, we all use 2.5 to 5 milligram, which has to be continued for 4 days. This belongs to atypical antipsychotic class of drugs. So high emetic regimen example is AC regimen that we use in the breast cancer. Coming on to moderate emetic potential, so the drugs used are mainly the doxorubicin at a dose of less than 60 milligram per meter square, cyclophosphamide less than 1500 milligram per meter square. So for these regimen, we use the moderate antiemetic risk. So we have to keep in mind that if we are using carboplatin at AUC dose of more than equal to 4, then we have to include NK1 receptor antagonist in that regimen. For that regimen, it will be NK1 receptor antagonist plus 5-HT3 receptor antagonist and a steroid. So on the contrary of high, which we use for 4 days, for moderately emetogenic risk, we use a 3-day regimen. And if we are not using carboplatin to the dose of AUC more than 4, we have to use the 2-drug regimen consisting of 5-HT3 antagonist and dexamethasone, that is steroid. So this we have to give for 3 days. Coming on to low emetic potential risk, so we can use only one single drug, either in the form of dexamethasone or 5-HT3 receptor antagonist. And for minimal, there is no routine prophylaxis which is needed. What about breakthrough nausea and vomiting? Whenever a patient presents to us with breakthrough nausea and vomiting, first of all, we have to see whether we have used olanzapine, 5-HT3 and steroid. If not, then we have to add that. Apart from that, other class of drugs includes metoclopramide at a dose of 10 milligram IV given 4 to 6 hourly. This comes by the name of Perinom. Or we can also use benzodiazepine by the name of lorazepam. The dose is 1 milligram. What about anticipatory nausea and vomiting? Ideally, prevention is the key, but if a patient presents to us with anticipatory nausea and vomiting, the drug of choice is lorazepam, which is given as 1 milligram 1 day prior to the chemotherapy at night time, and again it is repeated 1 to 2 hours prior to giving the chemotherapy regimen. So these are the few practical aspects. If we give aprepitant, it comes with a packing of 3 capsules. Here I've shown the packing. So 125 milligram has to be given on day 1 and 80 milligram on day 2 and day 3. We always have to counsel the patient not to forget taking 80 milligram on day 2 and day 3. Patients, they usually do forget to take day 2 and day 3 medication and present to us with a vomiting. So we always have to be aware of counseling the patients to take these day 2 and day 3 medications also. Ideally, it should be taken 1 hour prior to the chemo treatment. Then comes fosaprepitant. This is the pro-drug of aprepitant. This I have shown in this picture, and basically it comes as 150 mg vial, and you have to dilute it. First you have to reconstitute it with 5 milliliter of NS. Then again 145 ml NS is added to make the final concentration of 1 milligram per ml. This is only given on day 1 as IV infusion over 15 minutes. Why? Because it causes hypersensitivity reactions due to the presence of polysorbate 80. It also causes thrombophlebitis. Then comes steroids. We all know that it causes dyspepsia. So either it has to be given after food or we can use PPIs along with it. And it has to be used with caution in diabetic patients. Olanzapine, it is usually given at bedtime. Why? Because it causes sedation, and the doses I've already discussed, that it is 2.5 to 5 milligram. And another thing is that this olanzapine, it also stimulates appetite at a lower dose of 2.5 milligram. So this can also be used in patients experiencing concurrent chemo-induced anorexia. There was this Indian study which was done, which showed that if 2.5 milligram once daily is used for 12 weeks, then you can see that there was weight gain which was seen more than 5% from the baseline. And therefore, it was concluded that low dose olanzapine at a dose of 2.5 milligram once daily is simpler and inexpensive method of improving appetite and weight gain in patients undergoing chemotherapy and experiencing anorexia. So these are the certain class side effects. With NK1 antagonist, there can be headache, anorexia, fatigue, and derangement of the liver function test. With 5-HT3 antagonist, there can be headache, dizziness, constipation, QTC prolongation, and abnormal LFTs. With D2 antagonists like metoclopramide or domperidone, there can be extrapyramidal symptoms, akathisia, dystonia, tardive dyskinesia, galactoria, or QT prolongation. With benzodiazepines, the side effects are sedation, hypotension, and withdrawal symptoms. With oleans, weight gain we have already seen. Apart from that, it can cause extrapyramidal symptoms, constipation, and QTC prolongation. So this was all about chemo-induced nausea and vomiting. Coming on to our next topic, that is febrile neutropenia drugs. Febrile neutropenia definition is very important for all the residents. It is defined as single oral temperature of 38.3 degrees Celsius or 38 degrees Celsius sustained for more than 1 hour, and ANC of less than 500 or less than 1000, and a predicted decline to less than equal to 500 over the next 48 hours. So whenever we talk about febrile neutropenia, you have to understand that for febrile neutropenia, we give the drugs for prophylaxis in the form of GCSF. And if a patient presents with febrile neutropenia, we have to manage it with the antibiotics also. So I'll discuss both the scenarios today. Starting with the prophylaxis of the febrile neutropenia, you have to see what regimen we are giving and what are other factors, for example, comorbidities or age more than 65, then you have to risk assess the patient. For low risk, that is febrile neutropenia risk of less than equal to 10%, there is no prophylactic GCSF which is indicated. For risk more than 20%, equal to 20%, for example, we use dose dense AC followed by dose dense taxane or TCH, which is used in the breast. For that, we have to give prophylactic GCSF. And for the risk of 10 to 20%, we have to take into account other factors such as the comorbidities of the patient or age more than 65. Based on that, we have to decide whether or not prophylactic GCSF is needed. So coming on to prophylaxis, practically we mainly use two injections, that is one is filgrastim and another is pegfilgrastim. Before proceeding to that, you should know that there is difference between GCSF and GMCSF. GCSF is granulocyte colony stimulating factor, which targets only the neutrophils. For example, filgrastim, pegfilgrastim. And GMCSF is granulocyte macrophage colony stimulating factor. For example, sergramostim. It targets a wider coverage. It gives a wider coverage, acts on the myeloid cells such as monocytes and macrophages. For GCSF prophylaxis, we use either filgrastim or pegfilgrastim. Filgrastim is human GCSF produced by recombinant DNA technology. The dose is 5 microgram per kg per day. We round it off to 300 microgram, which is the most commonly used, which is given as subcutaneous single bolus injection given after 24 hours to 72 hours of chemotherapy. If we are going for bone marrow transplant, the dose is different. The dose is 10 microgram per kg per day, which is given as IV infusion. Doses and strengths, it comes in two forms, 300 microgram and 480 microgram. It comes either in the vial form or the pre-filled syringe. I've shown here the vial form of 300 microgram, which we commonly use in the clinical practice. Another important point to note is that it should only be stored in the refrigerator. So whenever a patient takes filgrastim to his or her home, they should carry that in ice box, and that has to be kept in the refrigerator, not in the freezer. The ideal temperature to store is 2 to 8 degrees Celsius, and it should not be freezed. Coming on to pegfilgrastim, this is again GCSF, which acts on hematopoietic cells by binding to the specific cell surface receptors, which stimulates proliferation, differentiation, and cell functional activation. The dose is 6 milligram, which comes in a single dose pre-filled syringe. This I've shown in this picture. It is also given subcutaneously. Single dose is required. And always remember that there should be at least 12 days minimum gap between the last dose of pegfilgrastim and next chemotherapy cycle. Coming on to toxicity, the most common toxicities associated with these injections are fever and bone pain. That is why practically we always ask patient to take a simple paracetamol of 650 milligram 30 minutes before taking this injection to counter this toxicity. Other toxicities are allergic reactions in the form of skin rash, urticaria, respiratory, for example, wheezing it can cause, and cardiovascular toxicity in the form of hypertension and tachycardia. Bleomycin containing regimen. So the bleomycin containing regimen, for example, ABVD or BEP, the studies have shown that if we use GCSF in that along with those regimens, it can cause lung injury, that is pulmonary toxicity. So whenever we give ABVD or BEP, we avoid giving GCSF. So another side effects are splenic rupture, ARDS, sickle cell crisis, and theoretical increase in the risk of MDS and AML. Coming on to febrile neutropenia treatment. So before going to febrile neutropenia treatment, you should know that what pathogens are causing it. And whenever we give some antibiotics, we should know that what coverage we are giving. So the common gram-positive pathogens are Querculase negative staphylococci, Staph aureus including MRSA, Enterococcus including VRE, Streptococcus pneumoniae and pyogenes. Common gram-negative pathogens are E. coli, Pseudomonas, Klebsiella, Enterobacter and Citrobacter. So whenever you assess the risk for febrile neutropenia, you have to divide the patients into two classes. One is low risk, one is high risk. How do you assess the risk? So there are certain index like MASCC index and CISNE index. I'm not going to go into the details of this index, but you should know what factors are included at least in MASCC index. Based on that and based on other factors, for example, if the anticipated duration of severe neutropenia is less than 7 days, and MACC scoring is more than equal to 21, with good performance status, patient is clinically stable, no organ dysfunction, patient comes under category of low risk. If the scoring is less than 21, or patient is clinically unstable, or anticipated severe neutropenia duration is more than equal to 7 days, or there is some organ dysfunction, then patient comes under high risk category. How do we manage? For low risk category, we can use oral antibiotics like ciprofloxacin along with amoxiclav combination, levofloxacin or moxifloxacin. For high risk, we have to give the broader spectrum coverage in the form of cefepime, imipenem-cilastin combination, meropenem or piptaz, that is piperacillin-tazobactam combination. The drug of choice, it depends on the local antibiotic susceptibility patterns. Based on that, we have to decide which drug we are going to use. So these all, they come under the category of beta-lactams. Beta-lactams include penicillin, cephalosporin, carbapenems and monobactams. Now, beta-lactam monotherapy is preferred over the combination of beta-lactam plus aminoglycoside. Why? Because it has lesser side effects, lesser morbidity and equal efficacy. The mechanism of action is that it disrupts the bacterial cell wall synthesis by binding to PBPs, that is penicillin binding proteins. These enzymes, they are essential for the cross-linking. Hence, when this cannot occur, there causes disruption of the cell wall synthesis. Another vancomycin or other gram-positive antibiotics like linezolid, they are not recommended as standard part of the initial antibiotic regimen. They have to be used only under certain circumstances. Another, aminoglycoside monotherapy alone should not be used as the empirical coverage. We're talking about aminoglycoside. This is the mechanism of action. This is the 50S subunit. This is the 30S subunit. In this 30S subunit, there is 16S ribosomal RNA. Aminoglycoside goes and attaches to this subunit, leading to misreading of the genetic code and inhibition of the translocation. The drugs included are amikacin, gentamicin, streptomycin, and tobramycin. The adverse drug reactions are they are nephrotoxic, neurotoxic, and ototoxic. So every time before prescribing aminoglycoside, we always have to check the renal function test, and it can also cause allergic reactions. Coming on to vancomycin, it belongs to glycopeptide class of drugs. The mechanism of action is that it goes and attaches to this. This is D-alanine portion of the peptidoglycan precursors. When vancomycin goes and attaches to this, it inhibits the bacterial cell wall synthesis, and therefore the cell death occurs. It mainly covers the gram-positive pathogens, and it causes infusion reaction. Very peculiar toxicity associated with it is red man syndrome. This is because whenever you give vancomycin at a higher infusion rate, it causes the hypersensitivity reaction in the form of urticaria, flushing, hypotension. So this you have to take care. Always and always dilute vancomycin in at least 100 to 200 ml of NS, and the infusion time should be at least 1 hour. Other toxicities associated are nephrotoxicity and ototoxicity. So vancomycin is not used in all cases. It has to be given only under circumstances. For example, the patient is hemodynamically unstable, there is positive blood culture, there is catheter-related infection or MRSA. The dose is 15 milligram per kg IV BD. The practical dose which is used is 1 gram BD given IV. Loading dose may be required in certain circumstances. For example, if we have severe Staph aureus infection, then we have to give. It mainly covers gram-positive organisms, does not cover VRE. For VRE, we can use linezolid. The dose is 600 milligram BD, either given orally or intravenously. It covers VRE too. So as I've already told, that modifications to the initial empirical therapy is done under certain circumstances, like there is antibiotic resistance, patient is unstable, or there is positive blood culture. For example, for MRSA, we consider the early addition of vancomycin or linezolid. For VRE, we consider the early addition of linezolid. For ESBL, carbapenems, and for Klebsiella, polymyxin colistin or tigecycline has to be used. Coming on to fluoroquinolones, the mechanism of action. So this basically directly binds to the bacterial DNA. It binds to the DNA gyrase and topoisomerase 4 enzymes. Therefore, it directly inhibits the bacterial DNA replication. The drugs included are ciproflox, levoflox, oflox, and moxifloxacin. It provides a broader spectrum. The adverse drug reactions are GI toxicity in the form of gastritis, hepatotoxicity, peripheral neuropathy, nephrotoxicity, hypersensitivity rash, and seizures. So these are the most common drugs which we usually use in the wards. These drugs and doses are cefepime given as 2 gram IV every 8 hourly, piperacillin tazobactam 4.5 gram IV every 6 hourly. We always have to check for the renal function test. If the creat clearance is less than 40, then we have to readjust the dose. Then the dose is 2.25 gram given every 6 hourly. Meropenem, the dose is 1 gram every 8 hourly. And for imipenem cilastin, the dose is 500 milligram given 6 hourly. Now, these 4 antibiotics, they provide a broader spectrum antibiotics. They provide coverage to the gram-positive bacteria. For gram-negative, we use amikacin. The dose is 5 mg per kg OD, and we have to assess for the renal function test and creat clearance before prescribing this. Then fluoroquinolones, ciprofloxacin, the dose is 500 milligram orally BD, levofloxacin 500 to 700 milligram IV or orally given once daily, and moxifloxacin. For anaerobic coverage, we give metronidazole. The dose is 500 milligram given 8 hourly. In certain regimes, like for multiple myeloma, we use trimethoprim sulfamethoxazole, which comes as a combination of Septran. And if we are using single strength, then we have to give it daily. If we are using double strength, we have to give at least 3 times a week. These antibiotics, they should be continued at least till the ANC is more than 500. Or if the patient has completed 7 to 14 days of antibiotics and all the documented signs and symptoms of infections are resolved, then from IV we can change to oral antibiotics. So now when to add antifungals. Antifungals are to be added if the duration of febrile neutropenia crosses more than 4 days, or there are new pulmonary infiltrates, or there is new onset of fever after defervescence, or there is positive blood culture. Now, if we talk about fungal infection, we have to keep in mind 4, that is candidiasis, aspergillosis, mucormycosis, and pneumocystosis. So here, this graph shows that whenever a patient of febrile neutropenia crosses 4 days, we always have to think in mind that it can be due to the fungal infection, and we always have to provide the antifungal coverage. So this is the graph which shows that if the duration is more than 4 days, mainly the culprit is fungus. Also, another thing to note is that as the species changes from Candida to Aspergillus to invasive mole, the mortality rate increases, and we have to provide the coverage accordingly. There are 3 main classes of antifungals: azoles, polyenes, that is amphotericin, and echinocandins. Coming on to azoles, there are 4 main drugs: fluconazole, itraconazole, voriconazole, and posaconazole. Before going to that, I'll explain the mechanism. So azoles, what they do is they inhibit this enzyme. This is responsible for conversion of lanosterol to ergosterol. Ergosterol is necessary for the fungal cell wall synthesis. When this is inhibited, ergosterol cannot be synthesized, cannot synthesize the fungal cell wall, and therefore fungal cell death occurs. Coming on to fluconazole, the dose is 400 milligram given once daily, either in the IV form or oral form. Once in neutropenic patients, once daily dosing is sufficient because of the longer half-life. And it mainly covers the Candida species, but we have to keep in mind that it is inactive against the molds. Similarly for itraconazole, and for posaconazole, the dose is 300 milligram BD given on day 1, that is given twice on day 1, followed by 300 milligram once daily from day 2. It is mainly used in the hemat malignancies such as AML and MDS. It covers Candida, Aspergillus, and the molds. It can be given both in the intravenous and oral form. In wards, we mainly use the tablet form. And PPIs, they decrease the posaconazole plasma concentration, so has to be used with caution with these. For voriconazole, this is the standard of care for invasive aspergillosis. Whenever prescribe a dose, we have to give the loading dose first, that is 400 milligram twice daily on day 1, followed by 200 milligram twice daily from day 2. If given according to the body weight, the loading dose is 6 mg per kg IV followed by 4 mg per kg BD. The toxicities associated are it causes significant renal dysfunction, visual disturbance, and hallucinations. Coming on to polyenes, that is amphotericin. So amphotericin is very important from practical aspect because you have to keep in mind that one is conventional amphotericin, one is liposomal amphotericin. You have to keep in mind that both these are given in the different forms. The doses are different. The dose for conventional amphotericin B is 0.5 to 1.5 mg per kg, and for liposomal preparation it is 3 to 5 mg per kg once daily given IV. I'll explain the mechanism of action first. So basically, these polyenes, they go and bind to ergosterol so that there is creation of the pores or channels causing leakage of the ions from the fungal cell wall and further cell death. So coming on to amphotericin, so you have to keep in mind certain practical aspects, how you have to give it. For convention, I have shown both these preparations over here. This is conventional amphotericin and this is liposomal amphotericin. For conventional and liposomal, better to use a central line because this causes phlebitis and you need to avoid that. So it has to be given with the central line, and always have to dilute in 500 ml of D5, not in NS. Before that, you have to pre-medicate with acetaminophen and diphenhydramine, and these are light sensitive, so you have to cover the antibiotics while on flow to protect it from light. So whenever you start amphotericin B, first you give just 10 ml very slowly. Then you wait for 30 minutes and check for the development of anaphylaxis because this is very important. If there is no anaphylaxis, then you have to continue the infusion at least over 4 hours for conventional amphotericin and at least over 2 hours for liposomal preparation. Always preload it with saline because it causes renal dysfunction. To prevent that, you have to preload it with normal saline and check the renal function test. Also check the potassium and magnesium levels as these drugs can cause hypokalemia and hypomagnesemia. Also avoid its usage with other nephrotoxic drugs such as aminoglycoside. Now, why liposomal preparation is better? This is because it has altered tissue penetration. It goes more in liver, spleen and brain and less in the lungs and kidneys. Therefore, there is reduced toxicity, reduced nephrotoxicity, reduced incidence of anemia along with the liposomal preparation. Therefore, because of lesser side effects, the patient tolerates it very well. This is because there is lipid vehicle which acts as reservoirs which reduces the binding to human cells. Coming on to the last group, that is echinocandins, and there are three drugs which we use, that is micafungin, caspofungin and anidulafungin. Caspo and micafungin, they are most commonly used. The doses are for caspofungin, it is 70 milligram loading dose OD followed by 50 milligram IV OD from day 2. For micafungin, it is 100 milligram IV OD. They mainly cover candidemia and invasive candidiasis. Few practical aspects. Fluconazole or echinocandin, it is used as initial therapy for most non-neutropenic adult patients, and echinocandin is preferred in critically ill patients. And whenever a patient has been exposed to azole already and patient has resistance to fluconazole, then we need to use a separate class of drugs. For example, we can switch to echinocandins rather than going to other azoles. This is because echinocandins, they target a unique site, that is the beta-glucan constituent of the fungal cell wall. So this is the unique site which is different from the azoles and polyenes, therefore to prevent the cross resistance, or if when the cross resistance has developed, we use echinocandins in such cases. Coming on to toxicity part, fluconazole causes nausea, vomiting, pain, rash, headache, transaminitis, and it is also CYP inhibitor. Because of this, we have to take care that whenever we are prescribing this medication along with other medications such as warfarin, this inhibits the metabolism of warfarin, so toxicity can increase, so you have to be cautious. So for voriconazole, there is QTC prolongation, visual disturbances, nephrotoxicity we have seen. Posaconazole causes mainly the GI effects like abdominal pain and diarrhea. Amphotericin B, we have seen acute effects are chills, fevers, aches, nausea, vomiting, and BP alteration. And the long-term side effects are nephrotoxicity, anemia, and CNS toxicity. Echinocandins, they have a better drug safety profile and they are generally well tolerated. So this was all about the drugs in the febrile neutropenia. Coming on to our next topic, which is chemotherapy-induced thrombocytopenia. So TPO is the main growth factor which is responsible for the stimulation of platelet production. Whenever we have thrombocytopenia, that is why we use TPO receptor agonists to counteract the thrombocytopenia. The current FDA approved receptor agonists are romiplastin, which is given in the form of injection, and other three like eltrombopag, avatrombopag, and lusutrombopag, they are given in the form of oral tablets. I'll start with the eltrombopag. The mechanism of action is that it interacts with the transmembrane domain of the human TPO receptor and initiates the signaling cascade, which causes proliferation of the megakaryocytes from the bone marrow progenitor cells. Therefore, the platelet production occurs. It comes in two strengths I have shown in the picture. This is the orange tablet, which is 25 milligram strength, and this is the blue tablet, which comes in the 50 milligram strength. It should be taken empty stomach. The starting dose is 50 milligram once daily, and you can increase the dose, and the maximum dose is 50 milligram once daily. The toxicity is mainly they are hepatotoxic, therefore the liver function tests are to be monitored. They can cause thromboembolic events, myelofibrosis, increased risk of hemat malignancies, and cataract. Coming on to romiplastin, again the mechanism of action is same. This is TPO. Romiplastin goes and binds to this TPO. This activates this signaling pathway, therefore it increases the platelet production. The strengths available are three strengths: 125, 250, and 500 microgram. I've shown here two strengths, 250 and 500 microgram. It has to be given in the subcutaneous form, and it has to be given weekly. Primarily they are approved, the FDA approved indications are for ITP and severe aplastic anemia. So whenever we give romiplastin, we have to keep in mind that the platelet counts, they increase 4 to 9 days after the administration. And therefore the weekly dosing is recommended. The starting dose is 2 to 4 microgram per kg. We can increase from 1 to 2 microgram per kg per week, and the maximum dose is 10 microgram per kg weekly. Our target platelet concentration should be up to 1 to 1.5 lakhs. The toxicities are headache and thromboembolic events. Coming on to the last topic of today. So this is about VTE prophylaxis. Whenever we go for VTE prophylaxis in patients, we have to always calculate the Khorana risk. So the Khorana scoring takes into account these factors. If the total score is less than 2, comes under the low risk category, more than equal to 2 comes under high risk category. Before prescribing any drug for VTE prophylaxis, always remember the contraindications for VTE prophylaxis, that is the active bleeding, platelet count of less than 50,000, indwelling neuroaxial catheters, neuroaxial anesthesia or lumbar puncture, any interventional procedure done, or previous heparin-induced thrombocytopenia. So these can be given either in the injection form or in the tablet form. For the injection form, we have deltaparin at a dose of 5,000 units subcutaneously daily, enoxaparin at a dose of 40 milligrams subcutaneously daily, and fondaparinux at a dose of 2.5 milligrams subcutaneously daily. So these three are preferred, but only in one situation we prefer unfractionated heparin, that is if the CRAT clearance is less than 30. Only in that situation this UFH is preferred. Otherwise, category 1 recommendation is to go for these three injections subcutaneously once daily. Coming on to the oral forms, we can use apixaben as 2.5 milligram orally twice daily, or rivaroxaben as 10 milligram orally once daily. We always have to check for the CRAT clearance before prescribing this. So this is all about the drugs in the supportive care. I have tried to cover up all the important topics from the practical as well as theoretical point of view. So my concluding slide. So what we covered today was chemotherapy-induced nausea vomiting drugs consisting of NK1 antagonist, that is aprepitant or fosaprepitant, 5-HT3 antagonist, that is ondansetron, palosetron or granisetron, steroids, that is dexamethasone, or olanzapine, that is atypical antipsychotic. For febrile neutropenia, we covered the prophylaxis in the form of filgrastim and pegfilgrastim, which are GCSF. And if the patient presents to us with febrile neutropenia, what antibiotics, antibacterials, and antifungals have to be given, that we have discussed today. For chemotherapy-induced thrombocytopenia, for all practical purposes, we use two drugs, romiplastin in the injection form and eltrombopag in the oral tablet form, which comes in the two strengths, 25 milligram and 50 milligram. For VTE prophylaxis, we can either use the injection form or oral tablets in the form of apixaben or rivaroxaben. So thank you for the patient hearing. That's all from my side.
Thank you, ma'am. Ma'am, I guess Dr. Faheema has just logged out. Karan, sir, if you're there.
Hi, yes, absolutely. So thank you so much, ma'am, for the nice presentation. And I think you covered a lot in a very short time. And I think then we'll proceed on to the next part of the session. So I would like to introduce our examiner for today, who's Dr. Ranjit Kumar Sahoo. Sir is an additional professor in Department of Medical Oncology at AIMS, New Delhi. And sir will be taking Viva for our examinee, who is Dr. Praveen Kumar. And he's a resident from Sri Shankara Cancer Hospital, Bangalore. Rahul, I'll just share the screen and I'll ask Ranjit sir if he wants to use this outline. So would you want the questions from the outline or would you ask questions? How do you want?
Can I have those slides with questions?
Yes, I'll just put them up, sir. Sir, is this screen visible?
Yes. Okay. So this is pretty straightforward. Now, please describe 5 chemotherapeutic regimens where we must use a 4-drug antiemetic regimen.
Good morning, sir. So in that case, we'll use chemotherapeutic regimens with high therapeutic, so high antiemetic, hematogenicity potential. We use cisplatin and adriamycin cyclophosphamide combination. Then in individual cyclophosphamide more than 1,500 mg per meter squared. Then in carmestin we will use, and then.
Okay, so could you maybe describe some protocols where cisplatin and adriamycin is used for which condition?
Cisplatin we are using in case of head and neck and cervical cancer along with radiation as concurrent regimen, and adriamycin and cyclophosphamide based combination we are using in breast cancer and also.
Okay, so for head and neck, when we use it with concurrent radiation,
Yes, sir.
what is the dose of cisplatin that we use?
If it is 3 weekly, we are considering 100 mg per meter square. If it is weekly, 40 mg per meter square, we are considering.
So, are you suggesting the 4 drugs will be used in either of these protocols?
In 40 mg per meter squared, no need of using this 4-drug protocols.
Okay, sir. So, most of these recommendations that have come up, it is mainly for single-used, combination or singular use of chemotherapy. So, for exactly with concurrent radiation, no such good quality studies have been published. So, if you remember a protocol called as cisplatin adriamycin protocol, which was used in osteosarcoma.
Yes, sir.
Do you remember what are the doses of cisplatin and adriamycin used in osteosarcoma?
We are using cisplatin. We are using 75 mg per meter squared. We are using.
Okay, so cisplatin is 40 milligram per meter square for 3 days.
Yes.
So that is 120, and adriamycin is 25 milligram per meter square for 3 days. So that is the most emetogenic protocol. And same for the breast cancer as well. The adriamycin and cyclophosphamide is also considered to be most emetogenic. Can we go on to the next question, please? So, could you suggest the drugs which are used for breakthrough vomiting?
Yes, sir. Ideally, we use metoclopramide in the form of a perinom, 10 mg IV 6th-hourly we will consider if there is breakthrough vomiting. Other than we can use olanzapine we can consider in case of breakthrough vomiting.
Okay. Okay, so that is a nice.
2.5 to 5 mg we can use.
Okay. So now there is a catch here. I mean, olanzapine, the non-inferior dosing of 2.5 to 5 milligram, that is not for breakthrough. Okay, that is for upfront use. For breakthrough use, I mean, a drug dose is actually, it should be somewhere around 5 to 10 milligram.
Yes.
But 2.5 milligram is a non-inferior dose, which is for upfront use.
Yes.
And the second thing is about perinom. Now, the usual dose of perinom is 10 milligram twice a day. And when we exceed beyond 20 milligram a day, then all these extrapyramidal symptoms, they tend to occur.
Yes.
So when you are using 10 milligram 10 milligram every 6th hourly, you should be a little careful about the extrapyramidal symptoms that the patient might develop.
Yes.
Okay, and the other concern about perinom is when the patient is also receiving olanzapine, the use of perinom can increase the side effects of extrapyramidal symptoms. So you should be careful. You should avoid using perinom and olanzapine together. Can we go to the next question? Okay. So what are the adverse effects associated with different classes of antiemetics?
Neurokinin 1 receptor antagonists like aprepitant, they are all associated with headache and this and then 5-HT3 receptor antagonists are associated with QT interval prolongation except palinosetron. And the extrapyramidal side effects are common with metoclopramide as well as olanzapine.
The most important clinically, sorry.
Dexamethasone, in case of diabetics, we should be more careful. And so dyspepsia is a known side effect of dexamethasone and all.
Okay, I agree. But the most important clinically relevant toxicity of 5-HT3 or aprepitant is constipation. The patient are going to complain a lot about it. The clinical relevant QT prolongation, it is not really clinically relevant, but we should be aware. So can we go down to the next question? Okay. So name 5 chemotherapeutic regimens where you use prophylactic growth factor, GCSF.
In case of adriamycin cyclophosphamide combination, we will use prophylactic growth factor. And in case of also in case of docetaxel cyclophosphamide combination in breast cancer, we'll use prophylactic GCSF.
Okay.
And in case of FLOT regimen, where we use docetaxel, oxaliplatin, and 5-FU based regimen combination, we will use GCSF prophylactic growth factor therapy.
Okay. Any other chemotherapeutic regimens which are used for hematological cancers? Let's say Hodgkin disease.
Hodgkin disease, it is known to cause bone marrow suppression, but since in Hodgkin's we are using, if we are using ABVD regimen, because of we are using bleomycin, we should consider avoiding prophylactic GCSF.
Okay, but there are other regimens apart from ABVD these days, and these drugs are available in our country and also approved. Let's say with BVABD, where you are using brentuximab vedotin with it.
In that case, we have to consider prophylactic GCSF, either
Absolutely.
with BVABD or nivolumab plus ABDs.
So there had been concerns about usage of bleomycin and GCSF together, but it is mostly avoided. It could be GCSF could be used along with ABVD. I mean, in past there had been some concerns, but recently I think there is no such concern. Where it is indicated, it can be used.
Yes, sir.
Okay, can we have the next question, please? Oh, that's an excellent question. What are the various strengths in which GCSF is packaged? And what are the various dosages?
So the strengths, it will come in GCSF, filgrastim will come in 300 and 460 mg vial it will come.
Did you say 460 or 480?
480, sir. 300 and 480 it will come.
Yes, yes. And they are available as both pre-filled syringes as well as?
As well as vial it is available, sir.
Perfect. So next question, please. Okay. So what are the most common side effects of GCSF administration? How will you manage them?
Fever. In certain cases, we can give prophylactic Dolo 650 tablet before half an hour to 1 hour before giving GCSF administration. And bone pain, which is very common, particularly in 1 or 2 days post GCSF. And splenic rupture are all rare complication side effects. With,
So they are very important answers. I mean, prophylactically, we need not use paracetamol because the incidence of fever is not much, which is clinically relevant. Bone pain is an important symptom. And before you administer GCSF, please place a hand to see whether there is splenomegaly or not. Most of the time it is not there. But in some occasional cases when there is splenomegaly, you should avoid GCSF. In those borderline cases. When it is absolutely indicated, you might use it, but then the incidence of splenic rupture can actually increase.
yes.
Okay, are these the questions or we still have one? Do you have another question? Perfect. How do you risk assess patients with FN?
There are 2 risk assessment scores. The most commonly used thing is MAFCC risk score, where if the score is less than 21, patient requires inpatient administration, there is high risk and all. And there is also CISNI index score. So based on which we can consider either oral, so outpatient management or inpatient management based on the recent IDSA guidelines, we can consider.
Okay, so most of the time in a clinic they are chemotherapeutic regimen based. So in which chemotherapeutic regimens you would always require admission? In cases where, like AML cases who are requiring induction, most of the time they are admitted, but if at all you are doing an outpatient induction, then they have to be admitted, be it AML or ILL. And be it in induction or consultation, especially with regimens like high doses of RSA. Okay. Do you have another question? Yes. So where do you offer prophylactic antifungals?
In patients with febrile neutropenia, if the fever and the neutropenia is persisted more than 4 days after giving this antibacterials, then we have to consider antifungals, prophylactic antifungals therapy. And in other cases, while in in hematological malignancies, particularly in AML, we have to consider posaconazole and as prophylaxis and all. In
any other setting apart from, let's say in BMT, where do you offer prophylactic antifungals? So in almost all cases of BMT, especially when there is anticipatory neutropenia, you can use prophylactic antifungals. And in cases where you're using steroids as in acute graft-versus disease, where you are using steroid at a dose of 1 milligram per kg, you are using prophylactic antifungals. Do you also use prophylactic antifungals in patients of ALL who are undergoing induction?
Yes, sir, we are using, sir. We have to.
The only concern is in ALL cases, because you are using vincristine, so there is an interaction, so you have to be a little more careful. So these are the cases where you could use prophylactic or let's say preemptive. I mean, type of azoles, basically. Okay, so next question. So in your practice, where do you offer prophylactic antivirals?
So while considering rituximab-based therapy, then we have to consider prophylactic antivirals
Okay,
in hematological malignancies.
perfect. What
And
else? Anything which is less intense? In botulism based treatment, you need to use
in myeloma, yes.
anything else? In post-transplant setting, you use prophylactic antivirals. Okay, so do we have another question? Okay, what are the FDA approved indications for romiplastim?
Romiplastim, even though we are commonly using, there is no FDA approval for chemotherapy-induced thrombocytopenia.
Mm-hmm. What are the concerns? I mean, what are the concerns of using romiplastim?
If the platelet count is less than 1 lakh, then we can consider weekly romiplastim in patients undergoing chemotherapy with
Okay, so do we have another question? So what are the warnings or precautions associated with romiplastim use? Because romiplastim, the other drug, eltrombopag, they are just like stem cell cookies. So especially in hematological cancers, there could be concerns of clonal evolution. So that's how, I mean, even though it is not proven beyond this thing, there could be a concern on warning. Okay, do we have another question? Yes. So what are the various risk scoring systems for VTE that is commonly used in the clinic? Okay. Do we have him? Yeah, hi, Praveen. So what are the various risk scoring systems for VTE? Or tell me a scoring system for VTE that we commonly used in clinic. So one is Corona score, which can be commonly used in clinic, especially for both for solid as well as heme malignancies. Next question, please. So what are the contraindications for VTE prophylaxis? Tell us some.
In case of GE malignancies with acute bleeding, then we have to consider cautiously, we have to use VTE prophylaxis.
So in any acute bleeding thing, you have to avoid prophylaxis. What else? Does it also be modified in cases of thrombocytopenia? So it is sort of contraindicated when the platelet counts are less than 50,000. And especially patient with, this CSF catheters. Next question, please. So when do you stop various anticoagulation drugs before surgery?
One week before surgery, we should stop.
Is it uniform for everyone?
No, sir.
Okay. Next question. So how do you manage febrile neutropenia?
So Based on whether based on score, we should whether first to decide whether a patient requires outpatient management or inpatient management. If outpatient management, we can give ciprofloxacin, or levofloxacin and discharge the patient. And if inpatient management, then we have to start. We have to admit. We have to start IV antibiotics, broad spectrum antibiotics. And
So
we have to
mostly in a
start.
clinical setting, and when you are doing an oral this thing, a combination of oral is more useful. Augmentin and ciprofloxacin is a good combination. What
Yes.
about high risk?
In high risk, we have to admit and start IV antibiotics. So covering all those coagulation necrosis staphylococci in gram-positive settings. And GCSF treatment we should start based on the neutropenia, based on the
So
level
what
of.
are the common antibiotics which are given on day one?
We can start with cefepime, cefoperazone sulbactam, or piperacillin tazobactam.
Are they used as a singular agents or you use a combination?
A singular agent is preferred, sir. Monotherapy is preferred.
Would you add amikacin?
No, sir. Initially, no, sir.
Okay, please look into those. Next question, please. What are the regimens which are associated with minimal risk of nausea, vomiting?
All the immunotherapeutic agents are associated with very minimal risk of chemotherapeutic induced nausea, CANV. And apart from that, oral TKAs are associated with minimal risk. Most of the oral TKAs.
Okay. Would you name some chemotherapeutic regimens which has almost zero chances of vomiting? Vincristine, bleomycin, they don't have any nausea or vomiting when used as a single agent. Okay, next question. So what are the precautions while using amphotericin B?
Hypotension is one of the commonest side effects, so we should monitor blood pressure. And so
when you start this medication, when you start there are at least two which are very common clinically. When you start this drug, there is incidence of drug reactions, which are immediate. You need to pre-medicate the patient. It can have a lot of shivering. And when you give it for a week or two, then there are chances of renal dysfunction and the associated electrolyte abnormalities. Okay, next question. So what are the recommended prophylactic antibiotics and vaccine in patients with multiple myeloma or CLL who are on treatment? What are the risk of infection? Maybe you can answer the first part. What are the risk of infection in patient with multiple myeloma?
Both bacterial and viral risk is there. So we will consider prophylactic Bactrim DS prophylaxis in double strength, preferably weekly thrice. And antiviral should be considered while giving treatment for multiple myeloma, particularly with bortezomib-based regimens.
Perfect. Next question. What is the approach to fungal prophylaxis in neutropenic patient undergoing induction chemotherapy, let's say for AML or bone marrow transplantation? So how do you do the fungal prophylaxis in these cases, like in high-risk neutropenia?
We have to start with posaconazole.
Okay. What is the dose of posaconazole and preparation? Okay, next question, please. Yes. So do we use any prophylaxis in CAR T-cell therapies?
Yes, sir.
So what are the prophylaxis that we use? Let's say bacteria, fungus, virus.
Antifungal and antivirals we have to use.
Okay. Which antifungal do you commonly use? Okay, next question. It looks like we are done with the questions.
Yeah, we are done with the questions, sir.
Yeah.
I think we'll take a few questions. We have Dr. Faheema with us, and we'll take a few
Perfect.
questions from the chat box. Dr. Faheema?
Hi, hello, sir.
Hi.
Hi.
Can you take a few
Hi.
questions with sir from the Q&A?
Yeah, sure. I'll come whenever there is a HEMAT-based question. Is it okay? Yeah, right.
Okay, I'll read out a few questions. Maybe I can direct it to sir. So
Yeah.
the first question says, can we give 5-HT3 antagonists other than day 1, 2, 3? And what would be the dose in that case?
Yes, we can give especially palonosetron. Palonosetron has the activity till 5 days. Granisetron, it is active for 72 hours. If you are using these long-acting drugs, then adding another ondansetron might have some minimal benefit. But going on to the other rescue drugs could be more preferable.
All right, sir. So the next question is from Dr. Alamin. He says, what is the dose of DEXA before docetaxel and paclitaxel, and how do you adjust for a diabetic patient?
Yeah, that is an excellent question. With all these new drugs that are available, the drug which has taken the maximum hit is dexamethasone. Dexamethasone is a very low cost drug. But when you look into the quality of evidence about the dose of dexamethasone, it is not that great. So it is mainly based empirically. So any dose which is between 8 to 12 milligram could be acceptable. Most commonly, the dose that is used is 12 milligram. When you are using dexamethasone, there could be some concern using ondansetron because it also, reduces the efficacy of ondansetron. So the dose of ondansetron, especially not palonosetron or granisetron, it has to be increased when you are using with dexamethasone. And the second part of the question was, what do you do in a patient who is diabetic? Would you modify the dose?
Yes.
In a clinical if it is not a very highly emetogenic drug, you should certainly reduce the dose to somewhere around 4 to maximum 8 milligram. And you should be very aware that the sugar control for that much period of time may actually require a little more stringent control while the patient is on dexamethasone, because dexamethasone is a long-acting drug. So for the next 2 or 3 or up till 7 days, the sugar control should be optimized. And in an uncontrolled diabetic, we need to avoid it as much as possible.
And sir, what about like a weekly dosing for docetaxel or pacli versus a 3-weekly, and a person who's had a hypersensitivity reaction in the last infusion? So do you also do some changes for the DEXA in those cases?
For docetaxel, there are a few things which are very important. When you are using docetaxel, especially as a single agent, it is fine. But when you are using docetaxel as part of a multi-drug regimen, let's say DCF, then you should be careful not using aprepitant in those cases, because aprepitant might pharmacodynamically increase the dose of docetaxel. So the preferred NK1 this thing should be fosaprepitant. And for a 3-weekly docetaxel, the dose of dexamethasone is somewhere around 12 milligram to start with. And post docetaxel, you give Visolone to take care of the fluid retention syndrome. This is for breast cancer. For prostate cancer patients, you are using prednisolone at a dose of 5 milligram daily, which is continuous. And for weekly paclitaxel, if the first week there are no reactions, you could omit the use of Avil in those cases, but steroid should be used in such cases because of the hypersensitivity which is associated. These are the specific recommendations for the use of weekly paclitaxel.
So for the 3 weekly, is there any role of increasing the dose of DEXA to 16 or 20?
Yeah, there could be some, but the quality of evidence is not that well understood. You have to understand the reactions of paclitaxel which happens, they are acute. And in acute reactions, the preferred steroid, if you have to use, it is preferable is hydrocortisone. But nevertheless, in many of these regimens, let's say with daratumumab or similar agents, we are using dexamethasone. If on dexamethasone the patient is having some acute this thing, then you are using hydrocortisone in addition to control the acute part.
Right, sir. Thank you so much. That was actually very helpful. So the next question is, instead of nadir, why do we give GCSF after ending of chemotherapy? That is the next day of chemotherapy. This is a question by Dr. Al-Amin.
Yeah, I'll take it. Actually, when it comes to hemat malignancies, the thing which we think about GCSF is like with any colony stimulating factors, like we have already spoke about clonal evolution with thrombopoietin agonist, right? That question also comes into play. So that is the only reason, even earlier days, AML, when we are giving 3+7 induction, we did not try to give GCSF, even when there was grade 4 neutropenias. But now we have data that it doesn't really matter, just like in FLAG-IDA or regimes like that, where we incorporate GCSF as a part of chemotherapy protocol. We really decide that giving GCSF is way better, and the outcomes are also better, especially in a country like India. So we don't want any abnormal clones or clonal evolution along with chemotherapy when we are giving GCSF. So we try to give GCSF 24 to 48 hours after chemotherapy. But in hematological malignancies, especially in cases like AML, where we are very worried about life-threatening febrile neutropenia and fungal infections, it is not an absolute contraindication that you should really postpone GCSF. If you have neutropenia or febrile neutropenia during the course of the chemotherapy, you can go ahead. We have data to back that up with GCSF as well. And another important thing we should be talking about when it comes to PEG GCSF and GCSF. I saw a lot of questions on that, Karan. Am I right? In the
Yes,
chat?
absolutely. Absolutely, ma'am.
Yeah. So PEG GCSF, the problem, especially with hemat malignancies, is right. Especially with subsequent chemotherapies, you already have a hyperplastic marrow after some intensive induction. So we cannot really anticipate when your cytopenias is going to kick in. So daily GCSF is a protocol we usually stick to, because with PEG GCSF, you don't know when the action is going to come. We expect it within 48 to 72 hours. We prescribe PEG GCSF only when you are not sure that the patient will take it, or he is not really aware of how to give himself a subcutaneous injection. So that is where, and why PEG, what is the difference between PEG GCSF and GCSF was the question. Just like any other drug, which pegylation actually improves or increases the T half. So when you want a longer cover, you give a pegylated product, just like pegylated elasparaginase, which has lesser side effects. It has multiple benefits. Pegylation, a molecule, has multiple benefits, like it can increase the T half and reduce the usual adverse effects which is associated with the native molecule. Anything else, Karan, I have to add to GCSF?
Ma'am, I think that's for the hemat point of view, that's I mean, that's a good explanation. But sir, I wanted to ask you, I mean, the time to peak or the onset of action for GCSF is actually a day or two. So it's a very valid question where the nadir is almost around 7 to 10 days, and we are starting with the GCSF on day 2 or day 3. So, I mean, would you want to comment upon that, sir?
So I think in the chat he asked why we are giving it on day +1 or day +2.
Sir, he also asked instead of Nadir.
Okay, instead of nadir. So why it is given on day 2? Because GCSF, it stimulates the stem cells into the peripheral blood, you know. And when you are using chemotherapeutic drugs, there is a risk that you are injuring the stem cells. And when it happens, then the chances of neutropenia on paper or logically might actually increase. That's why GCSF or PEG GCSF is actually administered 24 or 48 hours post the chemotherapy, because they will take another 1 or 2 days. By that time, the chemotherapy is completely out of the circulation. So there is no chance that the chemotherapies might injure this mobilized stem cells which are into the circulation. So why it is not used just at nadir and before that? That is a very interesting question, because these are all protocol modified and physician initiated initiatives. You know, when you look into some protocol like dose adjusted epoch, it is not prophylactic use of GCSF. It is used at the right moment. That I mean, but when you are using prophylactically, what is the exact advantage of over when you are using at NADI? It is very poorly understood. But yes, I agree. In a clinical practice, we tend to use it at day 5, day 7, day 9, or something like that. You know, that is a very valid question. We don't have an answer.
Right, sir. I think that was a very interesting question. The next question, I think, how do you know the risk of febrile neutropenia has already been answered? And how do you decide whether to transfuse blood or to use a GCSF or to use a GMCSF? Again, Dr. Alamin has asked this question.
So, Faheema, would you like to take it up?
Yeah, I don't use GMCSF anymore. I only use GCSF. And the blood product is, I mean, when your hemoglobin is less than 7 or there's a hemodynamic instability and the patient is having, some amount of pulmonary complications, that is the time I go for PRBC in patients with hemoglobin more than 7. Otherwise, the hemoglobin cutoff I use is hemoglobin of 7 for PRBC transfusion. I don't use any GMCSF. Currently, in any of the hematological malignancies, we don't use GMCSF because it has the same effect as that of a GCSF when it concerns hemat malignancies, and the side effects are way lesser. So we stick to GCSF, and yeah, PRBC transfusion is solely hemoglobin dependent in otherwise stable patients.
So since we have both a background of medical oncology and hematology, sir, would you please tell us that what are the cutoffs we usually keep for transfusing PRBCs in the medical onc setup? And ma'am, would you tell us about what is the cutoff for hemat?
Yeah, for hemat, hemoglobin of 7 in a patient who is otherwise stable with no other underlying pulmonary condition or cardiac condition is the cutoff we go for. It is not some magic number. I mean, we don't have much data. It was just assumed. The trials just happened around the hemoglobin of 7 because apparently the person who did all these analysis found a magic number of 7 to be very lucky or something like that. We don't have a data why the magic number is 7, but yes, 7 is the cutoff.
And is it somehow related to the underlying pathology, like something different in AML compared to something different in
No. It is a standard hemoglobin of 7 in no other, if the patient is having no other cardiopulmonary complications. If so, otherwise you will have to, target a higher hemoglobin. Otherwise, you have to be very judicious in using PRBC transfusion. We stick to 7. That is what the data shows in at least hemat malignancies.
Ranjit, sir, what about you?
It is all the same. And we actually initially used to follow 8, and because the daycare load was too much, so we are sticking to 7 in daycare, and in if the patient is admitted, we are sticking to 8.
All right, sir. The next question, I think Faheema ma'am rightly answered, filgrastim versus pegfilgrastim. And again, the next question is also answered, why do you give it 24 hours after therapy? Is there any specific criteria when to start romiplastim or eltrembobag? This is from Dr. Dylan Davis. Faheema ma'am, would you take it?
Yeah, so if you're anticipating a longer thrombocytopenia, that is the time you should consider, TPO agonist. Or if you're wondering, or the patient is at high risk for bleeding and the patient is also having febrile neutropenia. So that is the time I would consider TPO agonist, especially because we know the cancer associated VT is also a problem in these patients. When sir was asking the complications of romiplastim, that is the most worried thing, cancer associated thrombosis. So, if you are expecting a longer thrombocytopenia, that is, you have given a very marrow ablative protocol, uh, chemotherapy for the patient, or if this thrombocytopenia is hindering the next dose of chemotherapeutic cycle, so that is the time I go for TPO agonists, not otherwise. So, as long as the patient is having a platelet count of 20,000 or more, I'm happy and hale. Unless and until it is going to hinder my next chemotherapeutic cycle, and it has been happening, for quite some time. So, the counts before the chemotherapeutic cycle is also important, right? Say, for example, the patient is having getting his high dose methotrexate, and we see a persistent fall, and the platelet counts are not hitting your 50 or 70,000 mark for proper administration of the chemotherapy. So that is the time I would go for TPO agonists, not otherwise.
And would there be any difference if the patient had previously, like some time back, any episode of VTE, or he's at a higher risk of VTE? Would you still consider giving romiplastim for
So
that
it's
patient?
always a calculated decision. So if the patient has already had a prior VTE, so we should keep our guards high and maybe delay the chemotherapy cycle until he is fit enough and fulfills the criteria for the next chemo. So that is not an absolute contraindication; it's the physician's choice.
So how do you do it in clinic? Do you calculate a risk score and then give romiplastim, or I mean, it's more of
Yes,
a
yes.
clinical judgment?
We'll have to assess the risks of the VT, prior VT, what kind of, whether it was a superficial one or if it was a deep, I would really hold my horses and not go ahead with TPORAs. But if that has become like the dictum, all 3 doses of methotrexate was delayed because of concomitant thrombocytopenia, I really don't want them to relapse or have a CNS relapse. So I would go ahead with some TPO agonists. Romiplastim is my go-to, not L-thrombopar.
Right. Ranjit sir, anything from your side?
Yeah, I mean, the recommendations regarding the usage of romiplastum is not nice, but conceptually, when there are megakaryocytes there in the marrow, only then it is going to be very active. So it would work in cases where the marrow is still not ablated fully, when there is partial myeloablation. So I think careful modification of drug dosage can help. And normally, I do not recommend a lot of romiplastim use unless you are very clear that the malignancy is nowhere, especially if it is a heme malignancy.
Right, sir. Right. So the next question is from Dr. Ritwan. He asks, in BEP regimen, if neutropenia occurs, GCSF is absolutely contraindicated, or any other situation in which we could give it?
So it is, I mean, referring to the interaction between bleomycin and
Yes.
GCSF. So that possibility is actually averted fully. So you could use bleomycin and GCSF. It's okay to use GCSF, and BP can cause um, very terrible neutropenias, especially when there is heavy burden disease leading to hydronephrosis, even without change in RFTs. These are the cases where you use BP, let's say in full dose, and these patients they develop very severe neutropenias. So in these patients, GCSF should be used prophylactically, and you should space out bleomycin. If the bleomycin is to be used between day 8 and day 15, you should space out the use of bleomycin, or you might actually avoid it, especially in the first cycle on the day 8, day 15. And you could use GCSF on a continuous basis to know whether the how the counts are recovering. It can be used basically. GCSF can be used. There is actually no concern between G and bleomycin.
Right. I mean, would the total dose of bleomycin that has been given already be calculated and then take the risk of giving a GCSF? I mean, would that be one consideration, sir?
This is a very tricky question. The dose of bleomycin that is recommended to be used in germ cell tumors, especially in Europe, it is 30 units, day 1815 or day 2916, and it becomes 360. You know? And the in Europe the BSA is at least 2. And if you look into the usage of bleomycin in other conditions like ABPD, previously ABPD was used up till 8 cycles. So they used to use the capping dose which is meter square based. So they would never exceed a dose of 160 unit per meter square. So let's say 180 or maybe 200 unit per meter square is the capping dose for bleomycin. Now, in Indian setting, the BSA is somewhere around 1.5 or 1.6. If you go by the 360 units rule and a patient requires just 4 cycles of BP, which is a common occurrence in our clinic. If you go by the BSA, that is 1.5 or 1.6, it is easily exceeding 200 unit per meter square. So when you are intending to use 360 units, you should be very careful by monitoring the PFT and ELCOs every cycle. Every time the patient has some chest symptoms, you should be very careful using bleomycin. In patients who have a lot of lung issues, a lot of heavy metastasis in the lung there as well, the usage of bleomycin could be tricky. In such situations where you are expecting this patient is going to have surgery mainly in the lung field, those patients who have got primarily mediastinal non-seminimatous germ cell tumor, be a little careful of using BEP. In a heavy clinic, I would rather use VIP instead of BEP to avoid the pulmonary toxicities and subsequent resections, pulmonary resections, which has got a high possibility in the future.
Right, sir. Right. Thank you so much. So we have a couple of more questions. So the next one is, what is the importance of synergy antibiotic testing?
Okay. Who is going to answer that, Faheema?
Dr. Faheema, are you there?
Okay, so the antibiotic synergism, it is there. Basically, this is with respect to amikacin. You are using two antibiotics with different mechanism of action. This part was dealt pretty nicely by Dr. Akansha. Penicillins, they work differently. Amikacins, they work differently. Amikacin is a protein synthesis inhibitor, that is mainly a cell wall inhibitor. So you have to use drugs which has got very different mechanism of action. So it should ideally be a beta lactam with or without this thing BSI and usage of amikacin. The other, the testing to know whether they are synergistic and its clinical relevance, it is upcoming, and this has been done at many centers these days. And these synergisms are not for the first line use, they are for later use, especially when you are using a combination of, let's say, ceftazidime avibactam and something like aztreonam. These things are synergistic both in a clinical setting as well as in a preclinical when you really look for synergism in a culture. But most of the time, you should be using antibiotics which has got different sets of mechanism.
Yeah. Sorry, sir. I was just for a few seconds. Yeah, I don't use it in clinical practice anymore, but in resistant febrile neutropenia, right? Like, despite adding second antifungal, and you have used almost all your antibacterial which is available. Like you have used Zavicefta as well and injectable fosfomycin, and you're not able to control the fever. It does happen, especially after flag or 3+7. So then what I do is I do a maldite off with blood culture to check for, what is a resistance pattern, like for, what are the genes we are having, like Oxa and Klebsiella. So that is the testing I do. I do Moderator for bacterial resistance. And when we do that, they do give very beautifully the genes and the possible antibiotic combination that is recommended. So it is expensive, but then it is definitely life-saving.
Absolutely, ma'am. I think we can take the next question then. Can we consider fluconazole 200 mg once a day after giving 400 mg stat dose?
Faheema, would you take that?
No, I do go ahead with 400 mg only fluconazole. And as sir said, I would also like to say, since I mean, it was given from a Medonc perspective, in ALL induction, especially when we are giving vincristine, fluconazole has to be given very guarded. Especially like, most of the time I see ALL patients coming with fungal infections to me and they are on voriconazole. So that is the time when I'm very, very cautious during the vincristine dosage. The recommendation is that you don't give for 1 week before vincristine voriconazole. You stop it, but it doesn't happen. So in my clinical practice, what I do is I stop voriconazole 2 days before the vincristine schedule and then restart at the standard dose. And fluconazole dose is 400 mg. I don't reduce it to 200. I have seen some hematologists and oncologists using the dose of 200, but I don't. The recommended dose is 400 mg.
But we do use that 200 when, I mean, we have patient of multiple myeloma with the
The recommended dose is 400, Karan.
But for the crat clearance less than 50, do we?
Yeah, depending, of course, you will have to adjust the doses depending on creatinine clearance.
I think that is the only.
That is the only criteria. Otherwise, the dose is 400 mg.
200, yes.
The correct dose is 400.
400.
So if you have a normal creat clearance, you will have to go ahead with 400 mg.
So the next question is for DVT, when to switch on tablets, to a tablet form if earlier we had started injectable anticoagulant? Faheema, ma'am.
Yeah.
So
okay. So we already know that Apixa is as good as heparin. We have already established the fact. So if you have given 6 weeks of parenteral anticoagulation, that is heparin, you can go ahead with apixaban. Apixaban is my go-to when it comes to DOACs. And the other indication when you should not be considering apixaban is when it's a secondary DVT or there is no improvement in recanalization after 6 weeks. That time you will have to continue with heparin. Otherwise, after initial 6 weeks of anticoagulation with heparin, you can go ahead with DOACs. So it is non-inferior.
And the next question is, how do
One more thing, Karan, since we are supposed to give the caveats. Say, for example, you have given the patient had a cancer-associated VTE, and the patient was on heparin, and then you have shifted to DOACs, and he or she has the secondary thrombosis as well. That time you should not continue with your DOACs. The optimal way is to go ahead with heparin only. And even on heparin, while the patient is on heparin, he developed a second DVT. That time you'll have to increase the dose of heparin by 25%. So I hope I made this clear. Yeah.
I think that's very helpful, ma'am. Very helpful. So the next question is for the newer anticoagulants, oral anticoagulants, how do you monitor the effects?
We don't have the tests yet. Okay. Any test you do will be deranged. PT, APTT, everything is deranged. We don't have it yet. So you adjust the dose as per your creat clearance. And yeah, that is it. Unlike warfarin, we cannot do any tests to monitor whether they are really active.
Right, ma'am. Right. So the next question is, if patient has developed a grade 4 neutropenia on day 7 after taking PEG GCSF, do we need admission and prophylactic filgrastim and antibiotics, or simply wait and watch? Ranjit, sir?
Wait and watch.
All right, sir. Next one is for anticipatory nausea and vomiting, except olanzapine dexa, what else can we consider?
Lorazepam.
I think these are all one straight line answers. Any platelet growth factors for under 5 years? And if yes, then those.
Faheema?
5 mics per kilogram body weight.
Right. The next question is from Dr. Amol Rathod, and he asks, why is dose dense AC?
This one is already answered. I mean, when you are doing chemotherapy, you should use for the washing
Right.
chemotherapy out of the circulation. That's why you give it from day 2 or day 3.
Yes, absolutely, sir. So in Capox regimen, if counts are low on day 1 but able to receive oxaliplatin, when should I give GCSF, on day 2 or after capecitabine completion?
After capecitabine completion.
Right, sir. Should we give granulocyte transfusion or prefer GCSF in patients of relapsed ALL who has underwent induction for febrile neutropenia?
GCSF is nicer.
Right, sir.
Granulocyte transfusion for only cases which are severe and they don't have a lot of chest infections.
Right, sir. Because it'll cause a lot of cytokine release, right?
Yes.
Can GMCSF increase platelets as well? I think you've already taken that. There's a question by Dr. Atul Dongre. He asks if there is any role of erythropoietin in cancer chemotherapy induced anemia.
Yes, and yes. During
Right.
chemotherapy, if they are admitted, give blood transfusion, and then of course you have darbepoetin, erythropoietin, and all those. Yes.
Right, ma'am. So we have the last question for today. That is by Dr. Alamin. And he asks, what drugs can be used in bleomycin-induced pulmonary toxicity? Any prophylactic medication or measure you adopt, sir? And role of oxygen, steroid, and imatinib.
You know, this part is not very well understood. I mean, when you are using bleomycin, and let's say you are looking after a case of Hodgkin lymphoma, where you are doing PET scan, let's say after for 2 cycles of AVBD, and you are doing a PET scan, you might see evidence of bleomycin. And these patients may actually be symptomatic or asymptomatic. For patients who are asymptomatic, you stop blue and start medication. The only thing that works is steroid. And there are some papers which suggest that imatinib could also be useful. We have used it in quite a few patients of bleomycin toxicity, but we never had very nice results, or maybe we have chosen all the bad patients. The only thing that helps in these cases is steroid, and then there are case reports about some other drugs. Oxygen, because oxygen will further increase the bleomycin pulmonary toxicity, so the recommendations are not clear very. So anything which is 85% or above should be fine. You should avoid giving oxygen, especially in the acute stage. The only thing that works there is steroids and nothing else.
Right, sir. So we just had two more questions that just came up. Any use of GCSF in ribociclib-induced grade 3-4 neutropenia?
Because these are once you stop the drug, they come back very quickly. But if at all, if you have to use a singular, maybe 2 doses of GCSF. Otherwise, you stop the drug, they gets better. They get better.
All right, sir. And Dr. Alamin has asked a follow-up question to his last question. Dose and duration of imatinib you used, sir?
We have actually used 400 milligram, but because the mechanism is related to PDGFR, and anything which is 100 milligram and or above should work. But barring those case reports, we don't know whether these drugs are really useful, and these patients are very sick. So, and these are something like cytokine release. So the most important drug is steroids, and then there are other immunomodulatory drugs which could be easy. The role of imatinib in lung GVHD also, there are some reports that it improves the lung GVHD, but these lung GVHDs are not very acute. I mean, the tempo is slower. So if the bleomycin pulmonary toxicity is low, then you should use imatinib for a good period, because these are almost, they go into chronic. They might require many weeks to few months. And the dose that I would recommend is somewhere around 400 if the patient is tolerating it well.
Right, sir. Thank you so much, sir. I think we've covered all questions, and it was a really fruitful discussion into the nitty-gritties of supportive care. I will like to extend my thank you to you for taking out and sparing time on a Sunday afternoon. Also, Dr. Faheema ma'am, for the excellent discussion. I would like to thank Dr. Akansha, who was very supportive on the very last minute, and she prepared the slides. And also, I would want to thank Dr. Praveen, who was the examinee for today. I would like to invite you all for the next session, which is on the 6th of April. And we have Dr. Reena Nair on our stage, and we'll also have Dr. Anand Gokaran. We'll have Dr. Faheema again as our mentor. And our speaker is very dynamic, Dr. Alok Shetty from TMH Mumbai. And the topic for the next session is lymphoid neoplasms. With that, I would like to thank you all, and we would end the session here. Thank you so much.
It was a beautiful session, Karan. Sir, I learned a lot from you as well. I hope it
Thank
was.
you so much.
Yeah, I
Yes.
hope it was helpful for everyone who attended.
Absolutely, ma'am. We've had very, very nice reviews for
Yeah.
this. Thank you so much.
Yeah,
Chabbra,
what I
thank you
would
for
like to
inviting
say
me.
all is that, supportive care, again, I would say that they are the most important thing in oncology. When you are in an institutional setup, everyone knows what they are doing, like even the nursing staff from the peon. When you start practicing alone, then you will understand how much supportive care really is important and how much you need to teach the others as well. So you have to know everything firsthand before you can teach the others. You must be anticipating what might go wrong when and where. So I really think this is one of the most important topic we all, handling oncology patients should be aware of. And it was beautifully presented by Dr. Akansha within such a short notice. And yes, it was wonderful being there. And as usual, I always learn something new, always from Ranjit sir. Thank you.
Thank you
Thank
so much, ma'am. Thank you.
Thank you so much. All right. Thank you. We'll leave the webinar now. Thank you so much.